Vinayak, start the timer. Evening, everyone. It is our pleasure to welcome you to the third series of VERTICON, an exclusive initiative with AIB India Academy. It is my pleasure to introduce our host, Dr. Neha Shrivastava. Dr. Neha is a distinguished consultant neurologist and Vertigo and ENT specialist and director of the American Institute of Balance, India. With extensive expertise in vestibular disorders and neurotology, Dr. Srivastava is also an esteemed member of several international professional bodies and currently leads RTKL Vertigo and ENT Clinic and RTKL Diagnostics in Polyclinic in India. Without further ado, I would hand over the session to Dr. Neha. Over to you.
Yeah, good evening, everyone, and it gives me an immense pleasure to have you on this good sunny Saturday evening, hosting the third series of our Verticon program. With Verticon and our AIB has been quite successful in reaching out to the doctors all over India and internationally for creating the awareness of vertigo and balance conditions, and of course, it has made a huge difference to the clinical skills that are more required for the examination and treatment of the patients. Today, I have the privilege to have Dr. Suraj, who has been working regularly with me in and out in the OPD every day. A young champ with good expertise towards treating the functional and anxiety related cases with vertigo. I have Dr. Hitaf, a good friend and a good colleague from Nair Hospital, who is going to present today on the physiotherapy and the need of rehabilitation in vertigo cases. And of course, we'll be having Dr. Dinesh Singh, our consultant neurologist and a integral part of AIB India since its inception. So with this, let us begin the session for the day, and I would hand over the further proceedings to Pinakin Munshi, our Vice President for AIB India.
Thank you, Dr. Neha. Let me start by introducing Dr. Suraj Singh. Dr. Suraj Singh is experienced in independently managing outpatients, inpatients, and psychiatric emergencies for over 4 years across both government and private healthcare settings. Trained in various psychotherapeutic modalities, including biofeedback, cognitive behavioral therapy, dialectic behavior therapy, relaxation training, and other evidence based therapies. He is skilled in performing procedures such as electroconvulsive therapy. He served as a frontline healthcare worker during the COVID-19 pandemic, working in ICUs, wards, and casualty departments, managing COVID-19 patients at KEM and Seven Hills Hospital. With that, I hand over the platform to Dr. Suraj Singh.
Hello. Thank you so much, sir, for your kind words. So we'll go ahead with my presentation. Just 1 second. Yeah, is my screen visible? Yeah. So the topic for today, which I would like to present, is about mind balance connection and how anxiety and dizziness are related. Clinically, we see a lot of patients presenting with symptoms of dizziness, but on detailed inquiry examination, we understand that anxiety is related to the dizziness. Right, so psychogenic dizziness, it is defined as recurring or persistent symptoms of balance dysfunction, which is inconsistent with organic vestibular diseases, as we determine it by history, clinical examination, pertinent investigations. So all of these prove that it is consistent with an emotional origin. Dizziness is thought to be due to impaired integration between the sensory and motor signals, and particularly in patients with acute or chronic anxiety. Psychological problems, they are related to dizziness and vertigo symptoms in a complex way. They can be dually affected. They can be a cause as well as they can be a consequence of dizziness. Now we have seen clinically that at least 50% of the patients who report to us for dizziness, they have some or the other psychological disorders and predominantly anxiety. They can have reactive anxiety or depression. This has also been proven by a study by Sebastiano et al. In 2007, and it has been published. We clinically observe three groups of roughly equal size, which are as reactive psychiatric disturbances, that patients who have psychiatric problems after the dizziness, or some patients who have a primary psychiatric disturbance, and some which have a mixture of both. There were models for associations between psychiatric disorders and vestibular dysfunction. This study was done by Simon and Associates and was published in 1998. They gave three models for the association between psychiatric disorder and dizziness, where the first psychosomatic model explained that primary psychiatric illness can cause dizziness, vertigo-like symptoms, hyperventilation, hyperarousal, which then increases the vestibular sensitivity. Then there is the somatopsychic model, which is the reverse, that episodes of vertigo or dizziness can cause anxiety. Right? In these patients, there is hypersensitivity to the inner ear signals, and then they misinterpret the signals as an alarm or a threat. This also results in a negative conditioning. Then there is a network alarm model where panic is triggered by a false alarm via the locus ceruleus, which activates the neural circuits in the limbic system, the midbrain, and the prefrontal cortex. Now, what are the criteria for psychological dizziness? So, it's a chronic illness present for more than 3 months. It's a persistent daily dizziness. The patients will report these symptoms present daily. They also complain of motion sensitivity, so it increases with the use of vision. It's a non-localizing vertigo or dizziness. The definite localization is not possible. And the most important is there's normal examination, there's normal lab reports, there's normal scans. So all of the tests come as normal. And there is poor response to the standard treatment modalities, be it medications, be it exercises. There's not complete response to the dizziness. It's also a situational pattern. When we dig deeper and we ask about the history, we observe that they do not have episodes of dizziness during a vacation or during periods of relaxation, and the symptoms are more during stressful times. The psychosocial factors which we see clinically associated with chronic dizziness. So, gender, female sex, then of course stress, depression, or anxiety. People who have a short duration of sleep, so short sleepers. Those who also have some tympanic membrane abnormalities. Patients with chronic disorders like diabetes or arthritis. Also, people with psychomotor agitation or retardation are prone for chronic dizziness. The characteristics of psychological dizziness, how do we suspect that the element of psychogenic dizziness is present? There'll be continuous dizziness for long periods of time. It's predominantly observed in younger patients and predominantly female. There can also be some other symptoms of anxiety or a panic attack, like they will report of symptoms like headache, breathlessness, nausea, sleep disturbances, some paresthesia, some tingling sensations, and palpitations, heaviness of chest. This is a important feature where there's symptoms of aggravation due to stressful life events. Any stressful life event can precipitate the attacks. There's complete normal neurological examination, and the hyperventilation, we can ask them to reproduce it and they can reproduce the episode accurately. Now I'll come to certain cases where we had dizziness along with psychiatric comorbidities. Case one we had of panic disorder and agoraphobia. Mr. Chandrasekhar, 30-year-old IT professional male, he was living alone in Mumbai and his family was residing in Meerut, UP. He experienced a first episode of vertigo in April 2020. So 2020 during the middle of COVID lockdown, and he could not access any doctor. The episode, it was self-limiting. He didn't understand what to do and he took a paracetamol and he was better. Following this, he started excessive research about the episode, excessive searching, Google search, And then he started being preoccupied with vertigo. He was that constant illness, anxiety, and fearing that it must be something much severe. It can be a fatal illness. He also started experiencing other symptoms of panic like breathlessness, heaviness of chest pain. He then started with multiple investigations, multiple doctor visits. He would often seek reassurance from the doctors, from the relatives about his health, whether he will get better. He started showing avoidance behavior. So he started avoiding traveling, especially when alone. On detailed inquiry, we observed that he was an anxious and had an overthinking personality where he would think about things repeatedly. Another case we found was of somatic symptom disorder. Mrs. Sushila, she was a 50-year-old married housewife. She had complaints of chronic dizziness. The dizziness would not improve with treatment. She tried multiple treatment, investigations, MRI scans, multiple ENT visits, and specialist references, but all had been inconclusive. For such patients, they usually have a huge amount of files, huge papers, and she too reported of the same. She would report complaints of headache, back pain, fatigue, also of sleep disturbances, chronic gastric complaints like bloating, constipation, stomach pain, non-specific pelvic pain. She would deny any symptoms of mood disorder, any sadness, any anxiety. But understanding it as somatic symptom disorder, we did start with antidepressants, and she showed a very good response, and her symptoms gradually decreased. Another case we had of PTSD, post-traumatic stress disorder, where we found a 27-year-old single female who had a first episode of vertigo in Dubai. So she was traveling from USA to India on a long duration flight, and she experienced vertigo. Like most episodes of vertigo, she had severe nausea, vomiting. She had imbalance on walking, more on the right side. She even had a documented nystagmus. She then had to be admitted in the airport hospital at Dubai, and she reached India only after 5 days. All her investigations were normal. She was diagnosed as vestibular neuronitis. Now, because of these symptoms, she reported intense anxiety and associated with episodes of dizziness. So we usually call this as anxiety about anxiety. So she had the fear of vertigo, that what if this happens? How will she deal with it? And the flashbacks about that, the intrusive memories, the fear of hospital. She also even had nightmares around thinking or imagining of emergency hospitalization. She started avoiding all the situations which can cause giddiness or anxiety. There was a constant fear of another vertigo attack. Some phobic disorders also, where there is phobia associated with vertigo. So there's phobic postural vertigo. They complain of postural dizziness. So when they change their posture, they report of dizziness, and there is a fear of fall. But there's actually never any falls. Then they start avoiding the triggers. If it's any emotional trigger, any place which is there, they start complete avoidance of the place. These disorders, they usually, the phobia and the dizziness improves with exercise or on self alcohol use. They also, we observe frequent OC, that is obsessive compulsive traits with these patients, where they have obsessive nature or they keep repeating things. There's also hypersensitivity to the proprioceptive disturbances. So any change in the posture, any change in the balance, they are more hypersensitive to it. For such patients, occupational therapy, rehabilitation exercises have proven beneficial. Then we have conversion episodes or functional neurological disorders. We reported of a patient 20-year-old. She was a married woman. She complained of dizziness, brief loss of consciousness, occasional falls. And these complaints would gradually always be there after an altercation in the family. So any fights, any altercation in the family, she would have these episodes. There was a complete labile indifference. So this means that she was completely indifferent towards her episode. She was not afraid. She was not scared. The family would report her symptoms and she would be unaffected. She also had symptoms of disturbed sleep, anxiety. She had one episode of a pseudo seizure where she had tightening of the limbs and slight movements of all the limbs. Even in the past, there has been one episode of possession spell, and they, as family members believe, they had responded to faith healing. On detailed inquiry, counseling, and therapy, we understood that there was a marital discord. She had strained relations with her family, with her in laws, and eventually they separated with her in laws. And with counseling and treatment, her episodes subsided. We had another case of alcohol use disorder or alcohol dependence, where a 54-year-old sailor, he was brought to the emergency with severe giddiness, tremors, loss of balance, and falls. He had on history, we understood he had a 30-year history of alcohol dependence, and because of the lockdown, he had to undergo a forced abstinence. So on examination, he was confused, disoriented, tremors, visual hallucinations, ataxia, all features suggestive of a seizure episode. We gave the management line for withdrawal, which was injectable thiamine, benzodiazepine, and supportive treatment. He was discharged within 15 days. Even after discharge, there was cerebral ataxia and memory loss, and he was advised to follow up regularly, but there was loss to follow up. Some common cases which we can also usually see is that of malingering. So usually we saw a female 35-year-old. She reported of a chronic persistent dizziness, and for such a patient we had a waxing and waning course. The symptoms would increase and then decrease. The sometimes symptoms were more during the summer months. All her investigations were within normal limits. We had only received partial response to the treatments, and also the response was short-lived. There was acute exacerbation of the symptoms, and it would respond to simple hospitalization or just a saline infusion, and she would feel completely better. On a detailed psychiatric evaluation, everything was within normal limits. We found that she had some issues with the parents-in-law and with the husband. Frequent quarrels were going on, and she would avoid quarrels, she would avoid confrontation, and would report of these symptoms. We took them up for family therapy and for her individual therapy, and she got significantly better. Uh, we have the triple PD criteria, such as the persistent postural perceptual dizziness, the Barony Society criteria for the diagnosis. So these are the criteria. At least one of the following symptoms, that is dizziness, unsteadiness, or a non-spinning vertigo, should be present for most of the days. Symptoms for prolonged period, they do not need to be present continuously, and they can occur without specific provocation, but they can be exacerbated by posture, active or passive movement, or by moving stimuli or complex visual patterns. The symptoms can cause significant distress or functional impairment, and they are not better accounted by another disease or disorder. For assessment, we use certain scales. So we have a dizziness handicap inventory, which is a 25 question scale. And based on the points, we can describe as mild handicap, moderate handicap, or severe handicap. For mental health, we have scales like patient health questionnaire, which is a 9-item questionnaire. This even general practitioners or other doctors can use for screening of mental health disorders. For specific scales, we have Beck's depression inventory for depression and its severity. We have Hamilton anxiety and depression scale. This is a sample of the patient health questionnaire where even other doctors can use. It includes questions about depression, where there is questions about interest or feeling down or troubles with sleep or energy. It also includes questions about suicide, whether the person has been feeling that they are better off dead or hurting themselves in some or the other way. Now we come to the management. Once we understand that the dizziness is related to a psychological element, we have pharmacotherapy and we have counseling or psychotherapy. In pharmacotherapy, we use drugs like selective serotonin reuptake inhibitors, SSRIs like escitalopram or paroxetine. We usually start with the lowest dose, and based on the response, we can up titrate the dose. We also have serotonin norepinephrine reuptake inhibitors or tricyclic antidepressants, which work well with vestibular cases. Occasional use of benzodiazepines may be required to control the acute anxiety. The important element of treatment is the CBT or cognitive behavioral therapy, which we'll discuss further. There is occupational therapy, which consists of rehabilitation and vestibular exercises. One most important element is we advise to patients is starting exercise of daily physical activity of at least 40 to 60 minutes. Certain yoga techniques, which include balance postures like Vajrasan, Pranayam, which includes deep breathing, can also further help them, and meditation techniques, which we will discuss, which includes mindfulness or relaxation techniques. Okay, so this is a cognitive model of panic or anxiety, which we use. So for our patients, where there is triggers like palpitations, dizziness, some symptoms which they experience, and then there are external triggers like the situation, if they are in a closed space, if they are in crowded space. So what their brain or the mind does is that it has a faulty appraisal of the stimulus. So they fear that I am having another vertigo attack. Mild symptoms, but their perception is that they are having a vertigo attack. Because of this, they experience severe anxiety. They start experiencing severe panic attack. This is called as the catastrophic misinterpretation, where they misinterpret a normal stimuli as something very excessive. They then start having symptoms like physical symptoms of palpitations, breathlessness, dizziness. They also feel there is a lack of control, and they start searching for safety. They start avoiding these behaviors. They start safety behaviors. So then they will start avoid to go out alone. They will start taking rest. Then their day-to-day activities are impaired. This is a basic model for the CBT, and we try to work on each of the aspects to break this cycle and help them get better. So what components of the cognitive behavioral therapy we use is, firstly, we have to educate the patient about this cycle. We educate them about the role of symptoms, how avoidance and safety seeking behavior they are indulging it, how they are doing a body scan, that is they are placing too much emphasis on symptoms, even mild symptoms, but tends to emphasize too much on them. We also teach them certain relaxation techniques like deep breathing, JPMR, so that their physical symptoms of anxiety reduces. We sometimes try them with graded exposure to the stimulus from which they experience these symptoms. And there are certain behavioral activation techniques where we advise them to start doing their day-to-day activities with smaller tasks in the beginning. So deep breathing or box breathing or square breathing techniques. This is a very simple technique which we can teach in the outpatient department. We usually advise patients to start breathing in deeply, and they have to breathe in and count for 4 seconds. Once they have done that, they have to hold the breath for 4 seconds. Then they have to exhale the same breath and counting 4 seconds in their brain. Then again hold for 4 seconds. So this cycle of 16 seconds, they have to repeat at least for 4 to 5 times during a day. Sometimes when they are experiencing the panic attack, they have to repeat it again. Very simple mindfulness or grounding techniques, which I usually tell them if they are outside and they are experiencing some dizziness, some symptoms suggestive of anxiety. So I usually tell them that to look around them and see 5 things which they can see, to count 5 things they can see. Then once they have finished doing that, they have to see 4 things which they can touch. It can be very simple, 4 things which is around them. Then focus on 3 things which they can hear. So it can be any sounds, any noises, people talking. 3 things they have to name them. 2 things which they can smell around them, and 1 thing which they can taste. So they can take water during time, they can eat. What these techniques does is it takes their focus away from the bodily symptoms, away from the symptoms of anxiety to their present surroundings. JPMR or Jacobson progressive muscle relaxation. It has been present long time in our culture. It was called as Yog Nidra, and nowadays there's a lot of talk about it. It's described as non-sleep deep rest. What it does is we have to focus on each of our bodily muscles. We advise the patients to lie down and starting from the feet to lower legs, then upper legs, stomach, upper arms. Doing this, coming till the face, they have to contract each muscle and relax each muscle for a basics of 5 seconds. We teach them these techniques. We ask them to do it daily prior to falling asleep, or sometimes in the mid of the day if they are experiencing these symptoms, to follow this technique regularly. We need a combined approach of psychotherapy, physiotherapy, as well as medication, which we are discussing today. So patient experiences these symptoms, that is the fear, the health anxiety, the avoidance. They have the dizziness, unsteadiness. They then have a vestibular crisis where the role of vestibular rehabilitation exercises takes an important role. The role of physiotherapy for the movements, for balance, for changing their sensory inputs, and medications, of course, to control the acute symptoms. Okay, that's all from my side. Thank you.
Thank you, Dr. Suraj, for again excellent session, especially what you mentioned about the relaxation technique. That has always helped our patients.
Yes.
Especially in cases of those having an beneath the iceberg, the iceberg phenomena, having an anxiety disorder, and the superficial level presenting as triple PD.
Yes.
So it was an exceptional session, and of course we have discussed about malingering cases and recently in our
Yes.
1 or 2 cases. So Thank you so much, Dr. Suraj, for being a part of this program.
Thank you.
You can continue with the OPD. I can see you in the OPD, and we can come back in the panel discussion. Yeah, thank you so much. Okay, over to Pinakin, sir.
Yeah, thank you. So our next topic is being presented by Dr. Hitav Someshwar. Let me introduce him briefly. Dr. Someshwar holds an MPT in neurophysiotherapy, BPT and diploma in yoga therapy, a member of the World Rehabilitation Alliance and task force member of the Indian Federation of Neuro Rehabilitation. He also serves as an executive member of the Young World Federation of Neuro Rehabilitation's Special Interest Group, an accomplished academician with 72 publications in national and international journals and 6 textbook chapters. He has received multiple Young Investigator and Research Awards, including recognition from the World Stroke Organization in 2024, World Federation for Neuro Rehabilitation in 2022, Indian Academy of Pediatrics Women's Cell in 2021, and the Indian Federation of Neuro Rehabilitation Asia Oceania Society for Neuro Rehabilitation in 2020. So over to you, Dr. Someshwar.
Thank you for that kind information and your support. And at the outset, I would like to thank Neha Madam for having me here. And I'm just going to share my screen. Can you see my screen, sir?
Yes, doctor.
All right. So, uh, thank you, Pinangin sir, and thank you, Neha madam, and thank you, AIB India, for having me here. And it's a great privilege. And yes, talking about restoring balance in patients with dizziness and vertigo, it's a physiotherapy point of view as to how can we make a difference in these patients with dizziness and vertigo. It's an evidence-based rehabilitation because we believe in the world of evidence-based practice at present right now. And why dizziness and vertigo matter in the rehabilitation field? Because it has a huge socio-economic burden. In India, 8 to 12% of annual prevalence of dizziness is present. 100 million people roughly are getting affected by this. The healthcare cost goes up to 4 to 6 lakh crore per annum, and there is an increased fall risk with 30 to 40% of elderlies experiencing dizziness, and out of which 40 to 50% people are having falls, and we all know how bad falls is and how it affects us. So it's always better to understand why dizziness and vertigo and why rehabilitation in these patients. So the burden of imbalance, it is a lifespan perspective. It deals from pediatrics to adults to the geriatric. Yes, the prevalence keeps changing over time, but the pediatric has a prevalence of 5.3. It has an impact on motor delays and on reading difficulties as well. In adults, the prevalence is around 1.4, and it is an acute incidence that occurs. There are no chronic cases in the adult population. But as we discussed previously, where Dr. Suraj was explaining about cases, it does have an impact on the work loss as well as the anxiety that is associated with disorder and geriatrics. The I can go on and on talking about it. 30 to 45% of the prevalence is present in the age group of above 70 years. It leads to falls and fracture risk in these patients. So, what is the clinical implication? You have to early identify and treat vestibular dysfunction, and it is essential for fall prevention and maintaining functional independence in the aging population. So, please, as a physiotherapist, to the fellow physiotherapists and to fellow physicians also, always check for the orthostatic this thing, and always check for that early sign or check for the vestibular dysfunction sign so that we can prevent fall in the earlier stages. I'm just going to cover up slightly. We all know it's the vestibular apparatus, the vision, and the somatosensory system, which works together along with the vestibular nucleus and the cerebellum to maintain that sensory rewiring that is there. And any problem in any one of these can have an effect. on the vestibular problems with vertigo and dizziness. So assessing all three is of varied importance right now. So we all know that there is a sensory input that is there, then from the vestibular system, from the vision system and the proprioception system. Then there is an integration of all of these inputs by the cerebellum and the cerebral cortex, along with certain channels at the brainstem also. That leads to a motor input of the vestibular ocular reflex, the motor impulses to control the eye movements and to make postural assessment. And that is how we are staying in a balance and in an equilibrium position. So, an injury anywhere in the sensory input, in the integration of the input, or in the motor input can lead to balance problems. So, the physiotherapist or a rehab professional has a role in this at various stages that is present. So, what is the functional impact that occurs because of the functional impact? Because of the dizziness, there is an increase in the postural sway, there is delayed reactive responses, the visual dependency increases in the adult population. There are altered hip strategies so that when they are having certain perturbations or certain loss of balance, recovery of balance become difficult, and these leads to a lot of psychosocial impact. There is reduction in active participation, there is increase in fear of falling, increasing in anxiety and depression. At the end of the day, what happens is it reduces the quality of life of our patients over here. Then there are certain gait abnormalities also there. There is an increase in the step length, there is lower gait velocity, there is an increase in the step width, there is reduced head movements during walking, and there is difficulty with head turns when they are walking as well. So, as a physiotherapist, what are the clinical assessment approaches that we should do? Is a history, red flags, again the physical examinations for vital signs such as orthostatic hypotension, neurological examination, ear examination, eye movement assessment, gait evaluation, and also the cervical spine screening. Once you think that there are certain indications which tell you that this could be because of the vestibular system, we have a lot of tests which can be done by us also as physios or as rehab professionals. But generally, when a patient is sent, these all tests are diagnosed and be presented by the either the neurologist, the psychiatrist, or the ENT surgeons that are there. And it says that if you have taken a thorough history, 70% of vestibular conditions can always be differentiated, and always screen for central causes before before doing any positioning testing like the hints plus that is there, because these are the silent killers that are there, which obviously Dr. Dinesh Singh would be explaining in the next talk over here. Now, how is the assessment different between the adult and the pediatric population? Because I deal with a lot of pediatric vertigos as well and pediatric balance issues. So I thought I would just touch up on this. Is the adult presents with a rotational vertigo, they come with nausea, they come with specific triggers. A child cannot understand what is happening, they're clumsy, they're just having a lot of motor delays, there is no neurological insult, there is no issue per se, but the child is not having his motor milestones achieved as and when we need. They're poor in class, and they have motion sensitivity, they cannot go for field trips, and they are just bullied by their peers, and that is when these patients come to us after roaming around 100 places. And the testing, again, for the infants and for the children, it has to be for the writing reflexes, and for the children we are seeing it in a functional play manner and the rotatory chair manner, because they're not going to follow your commands in the way an adult patient will follow. So we need to modify our approach in assessing these patients as well. And coming to the geriatric population, we know there's a vicious cycle. Dizziness can lead to fear falling. Fear of falling can cause sedentary behavior. Sedentary behavior will again lead to deconditioning. Deconditioning becomes an increased risk of fall and thereby causing an increase in dizziness. So that's a vicious cycle which we as professionals need to break it, so as the professionals, the patient's quality of life improves. And so the clinical framework in terms of physiotherapy, we need to check for the static balance as well as the dynamic balance. We do a lot of functional gait assessments. Our center has a functional gait lab So we generally take our patients into into those labs, and we assess the patient based on the criterias that are there. And static balance, again, we know happens in four conditions: with eyes open on a normal surface, eyes closed on a normal surface, eyes open on a foam surface, and eyes closed on a foam surface. So this tells us about the vestibular system, and it tells us as to which system is overcompensating or which system is in dysfunction at the same time. What are the principles of vestibular rehab? We always believe that one size does not fit all. Today, if I'm a plus size, I go to say an X shop. A 2XL is not going to fit me, a 3XL will. But does that mean that the other shop will have a 3XL that fits me? No. So, it's the same way, like all rehabilitation, for vestibular rehabilitation, also, we need to have individualized exercise prescriptions. It cannot be one size fits all, just giving a prescription as to do these exercises, go home and let's see what has to happen. That doesn't work. Again, the second one is progressive difficulty. Do not go for the hardest exercise first, go slowly and then start uh, challenging the patient and thereby improving the vestibular system. Again, there has to be specificity of training, target specific functional limitation, and symptom triggers. This will lead to and include that activities that challenge the patient specific problems. So, certain patients might have issue with repeated hospitalizations, or those post-traumatic stress disorder patients. So we always believe in doing a specificity of training them in that particular environment. I'm going to come to how do we do that in the coming slides. Patient education works important because certain times, addressing the fear, addressing the anxiety does help. So talking to them, and cognitive behavioral therapy, as Dr. Suraj also explained, it does work in having that talk with our patient and having the uh, that moment with that patient where all the doubts of the patient are cleared, and addressing the psychological factors. I'm not going to take much of your time with this because Dr. Suraj has already explained this. And we have a multidisciplinary team which looks into this. It has to be a neurologist, an ENT surgeon, a physiotherapist, an audiologist, an occupational therapist, a psychologist, then general physicians, rehabilitation nurse, the ophthalmologist, as well as the orthopedic specialist. So these are, I'm not going to read it out because everyone knows their role, but we need to know that, it's a teamwork together, everyone achieve more. It's not like one person can do everything. And that is what AIB India is also trying to prove over here, that everyone has to come together, everyone has to work, and we need to take it forward. So basically, for the vestibular recovery or the rehabilitation, when I was just going through literature during my undergraduate, postgraduate time, and recently when Neha ma'am asked me to present on this topic, we always think about there are three pillars of vestibular rehab. One is adaptation, the second one is substitution, and the third one is habituation. So adaptation, it drives the central neuroplasticity to tune the VOR gain that is there. The substitution, it utilizes alternative strategies like the cervico-ocular reflex, the smooth pursuit, or the visual and somatosensory cues that are present. Habituation, it helps in systematic desensitization to motion provoke symptoms via repeated exposure. I'm going to discuss all three in detail over here. So rehabilitation pillar one is the gaze stabilization, which helps in the adaptation. The retinal slip that we need to drives the long-term potential in vestibular nuclear to reset the VOR gain. So we do that. It must include patients with mild symptoms to be effective in symptoms which are severe. Callinesthetic repositioning along with medications need to be taken, and then this is as complementary or an adjunct to those therapies that are already being discussed and are already being seen. So adaptation, it's a neuroplastic recalibration of the vestibular reflex through error-based learning. The cerebellar mediated adjustment of VOR gain to restore the retinal image. Stability during head movements is what is there. The gaze stability exercises, that is the VOR X1 with retinal slip as an error signal that is used, and it can take days to weeks to help, and it requires repeated practice with error feedback that the patient requires, and the number of times also need to be checked. we always need to know that the head velocity has to be, the head movement has to be high, that is 240 degrees per second. To optimize this adaptation, it does not have to be in the same range. The range has to keep changing, the speed key has to keep changing. So I have got a few exercises for you. This is VORX1, where we are keeping our hands stationary and the eyes are moving front and back. Then the second one is when the head is also moving and the pen is also moving, and but your gaze is stabilized onto the pattern that is there. Then there is an imaginary VOR where the patient's eyes are open, then they close their eyes and then they open. They have to imagine where it is going to be and they have to stabilize the gaze. And then there is a two target VOR that is there, where we keep looking from one end of the pattern to the other end. Along with, first we stabilize the gaze and then we have the head movement that is occurring. Then there is a VOR cancellation one also, where we move in the same direction, and or else there is another one where we move in an opposite direction to the movement of the eyes. So these again, you start with VORX1, go to VORX2, and then you keep progressing. Do not start with the most difficult one, because instead of improving the symptoms of the patient, you are going to challenge them and you're going to make it worse. So generally, based on the evidence and literature that is available, we need to do this in the acute and subacute for greater than 12 minutes per day. The target velocity should be 240 degrees per second. In the chronic stage, it should be greater or equal to 20 minutes per day. Duration should be short bouts, but with high velocity. How do you progress? First, it is seated with slow head movements, then standing with moderate feet, then standing with high velocity, and then you want to do it while walking. And research shows that focusing on achieving a high velocity in short bouts and produces superior outcome compared to the traditional duration focused approaches. And if patient cannot maintain the focus, come back, reduce the speed and increase the size of the target that is there. The other two pillars, as we know, is habituation and substitution. It reduces the central response to provocative stimuli, best for central sensitivity or migraines that are there. And the substitution is better for the force, which reliance on remaining cues. So it is best for bilateral cues, and it helps in improving through the increase in the proprioceptive or the somatosensory stimulation. So substitution, it will use an alternate sensory or motor strategy to compensate for the vestibular loss. There is an increased in reliance on the visual and the proprioceptive symptoms or the proprioceptive inputs that are present. Exercise application can be with balance training, with sensory manipulations like doing your exercises in with a wide base of support, with a narrow base of support, standing on a balance beam, standing on an uneven surface, again with eyes open and eyes closed, and having certain saccadic eye movement training. Again, it takes weeks to months and develops as adaptation limits get better. And again, this is not possible, or it has lesser input when the vision system is involved. So in the elderly, if you involve the ophthalmologist, correct the vision of the patient, it does help. And the third one is the habituation. It helps in reduction in response to repeated proactive stimuli through the CNS desensitization. We've got wonderful results for patients with motion sickness, with motion induced system responses, those are there. And repeated exposure to symptom provoking movements and visual environments is the one that is helping. Uh, it takes weeks or months to get better, and it requires consistent daily practice for this to occur. And primary mechanism for triple PD management, I found this in literature, but again, there are different ways in which it works. You can even provide a cocktail of all three and see what best works for the patient. And as I said, it has to be individualized, so your patient's goals need to keep changing. So habituation exercises, we have the Brandov's exercises, the Caxian Cooksey's exercises that are present. It involves a lot of head movement exercises, visual motion exposure. We've been doing a study recently on optokinetic stimulating training, We are just waiting to finish collecting of our data, and we'll have the data available on some of the better journals that are there. And again, complex visual environments in which taking them to the shopping malls, taking them to busy streets, so that the visual and the sensory stimulation does occur in these patients. So again, dosing, you start below threshold, then you gradually progress. Daily practice is essential, and an expected timeline of 4 to 8 weeks is necessary. How do you progress? You start from simple movements, then you have combined movements that are present, and then you have dynamic activities that are there. And then we go in for complex environments, like actually putting them in real world, whether it's in the actual world or in a stimulated world. This works for triple PD in motion sensitivity, visual vertigo, chronic dizziness with maladaptive compensations. The again ensure the safe environment, because that can lead to a lot of discomfort, lot of symptom provocation at times, and the patient should feel challenged but not overwhelmed, and monitor for excessive anxiety in our patients over here. Then balance retraining, again, static balance, dynamic balance, sensory manipulations that should be there. You have to progress from a stable surface with eyes open, from the stable surface, go to eyes closed, go to an unstable surface with eyes open, unstable surface with eyes closed, and then add head movements so as to challenge the vestibular system more. Again, 3 sessions per week, minimum 11 to 12 weeks is optimal to get any results. A session should be for 31 to 45 minutes, and it should be for the best outcomes. And a 10-year equivalent rejuvenation and postural control has been proven by the evidence that is present. And see to it that when you're doing these balance activities, have functional task integrated into it, such as sit to stand, reaching to floor, turning while walking, obstacle negotiations, and always work with dual tasking in our patients. Again, gait and fall prevention is very important, because with dizziness, with chronic dizziness, still your symptoms are resolved with medication and with rehabilitation and with psychotherapy. We need to prevent having falls. So patient education is important, home medication. The assistive devices need to be prescribed, and you cannot take whatever you want. Vision checking is important. Medication review, because they are on polypharmacies. So it's always better to see if there is any drug interaction which is causing these increase in dizziness episodes, and take care of the footwear also and the flooring in the house. So the world guidelines suggest three greater than 3 sessions per week for 4 weeks for fall prevention in older adults with dizziness or without dizziness as well. And again, case specific trainings need to be involved in that. Now, coming to this most important thing, we as physios and we as rehab professionals are scared to refer our patients, or are scared to send them to higher professionals or to different professionals when we cannot maintain this. I per se, in my earlier days of practice, had a lot of cases which could have been better if there were timely and early referrals. So again, what we made a practice in our center or in our practices, all the multidisciplinary members will see a patient with vestibular dysfunction. So as a different set of eyes do not help or do not harm the patient, mainly by treating them, and everything comes in. The red flags, Dr. Dinesh Singh is again going to explain in the next talk, so I'm not going to talk much on it because I'm not an expert per se in that. But know when to refer a patient, because we don't want to do harm to our patient and we want our patients to get better. So this is an interesting case of a 68-year-old female who had positional vertigo, which was present. The patient was seen by an ENT surgeon at our center, and the patient had a positive Dix-Alpic test. The head impulse test was normal bilaterally. She had a cautious gait, but she was walking normally. It was diagnosed as a right posterior canal BPPV. We used the dizziness handicap inventory scale. We use the work balance scale, and the functional limitations included bed mobility, looking upward activity. The prognosis was excellent with appropriate treatment. Session one, on day one, the Aplis maneuver was done by the ENT surgeon, and the positioning and the patient education was done well. And in the second week, we in the first week, in the second session, we started initiating the rehabilitation protocol. And after 4 weeks, the scores improved significantly. The patients symptoms resolved completely, and normal ADLs were there, and the patient was discharged with an home maintenance care. So it says that after the canalitic repositioning also, there might be some residual vestibular problems or this thing which can be triggered or which can be assessed, and then you want to treat your patient well so that the reoccurrences are less. So again, refer your patients for the long term rehab so that the patients do get better. So all three mechanisms, that is the three pillars, operate simultaneously during vestibular rehab. Exercise selection should target the dominant mechanism for each patient's specific deficit. Adaptation exercises for VOR deficit, substitution for chronic unilateral loss, and habituation for motion sensitivity is something that we need to look at. And certain times patients do have overlapping symptoms, so you need to use two or three mechanisms for that. Coming to how is modern technology changing our clinical practice, the most important thing that we have is the virtual reality that is coming in, where the patient is made to do exercises or is made to do home exercises or even in say, a person exercises in a controlled environment wearing the goggles. There are three types of virtual reality, where immersive, non-immersive, and semi-immersive. The ones where they wear the virtual reality goggles is an immersive type. I know we might have all gone and seen it with those 6D movies and the 4D movies and things like that. So this is helping us in rehabilitation. It gives us these immersive environments. It has interactive balance tasks that are there. There is again rewarding that is present in the patient. So there is engagement of the patient, and virtual reality has been proved useful for vestibular rehab, for pediatrics, for adults, and as well as the geriatrics, because there is adherence to therapy that is there, because there is reward based and there is a competitive nature that is present in that. Now, the other thing that is coming is data driven biofeedback. It is quantifying the recovery that is there. A lot of variables like smartwatches and sway meters and all have come. They are wearing those, and these are connected to our smartphones, or they are connected to a cloud server which your doctor can see. And again, if the sensor detects sway, the data is analyzed in real time. It is delivered. There is a vibrotactile feedback that is delivered, and the patient corrects or actively corrects his posture so as to prevent fall. The IIT, I forgot which one. The IIT Gandhinagar has been collaborating with the Indian Federation of Neuro Rehab in developing these sensors for detecting vestibular or to detect epilepsy also. So these are all things that are coming into the market. We shouldn't be afraid of it, but we need to know how much data is needed. वो दे देगा 10 पेज का report. How much is going to make sense to us is when we are going to start using it, and when we are going to get trained, and when we are going to understand the pathophysiology of the disease, we are understanding what data is important to us. Now, the other thing which COVID has taught us, and what has been happening, is the access with tele rehab therapy beyond the clinic. Certain times the patient is vacationing on the beaches of Bali or Maldives, and suddenly they get vestibular symptoms. And I know a lot of neurologists and ENT surgeons, and there is a lot of evidence that tele-prescribed repositioning maneuvers are also helping our patients. And certain times when the patients are busy and they cannot travel because of X and Y and Z reasons, tele-rehab does help in these patients. And it connects the doctor from the home into the residential facilities and things like that. So it keeps connectivity among all of them. And there are next gen therapies that are coming, which are again in the earlier stages. We are yet doing it. Augmented reality is one of them. It integrates the digital information into the user's view of the real world. metaverse, and all of this is working. We at the Indian Federation of Neuro Rehab, under the able guidance of Dr. Nirmal Surya, are developing augmented reality or a metaverse for our patients to experience rehabilitation in a better way. There are robotics and there are different other stimulating devices. There are different machines that have come which help in balance reintegration. Again, these are all in the earlier stages. You have to see for the cost effectiveness of the machine. You have to see whether is that actually necessary for the machine, and there are a lot of robotics that are there. The other thing, I am not very sure about this, but I just came across literature which talks about a vestibular implant which stimulates the vestibular apparatus. I am not sure as to how valid is this for us in an Indian population, but this is coming into the literature now. Maybe Dr. Dinesh or Dr. Neha or Dr. Pinakin might be the best people to answer about this. So the future is bright. We don't have to be scared about it. We have to look it in a better manner so that we can embrace it. AI is not going to replace us as doctors. So we have to be there. We have to work along with it to get a better outcome for our patients, thereby improving the quality of life of our patients. And before I finish, we need to just summarize a few things. Early intervention improves outcome. BPPV does require canalitic repositioning. Triple PD needs a combined approach of a multidisciplinary team. Exercise dosing does matter. One size does not fit all. Patient education is crucial. Objective measure is needed so that you can form objective measures and you can tell your patient, and it does help in research as well. Multi approach is necessary, multidisciplinary, because together everyone achieves more, and balanced training reserves the age related decline. I cannot stop aging, but I can make it graceful for them, is what should be a motto of a physiotherapist, and get it better for our patient. And these are the evidences that I had gone through while preparing my slide. And that's all from me. Thank you.
Thank you, Dr. Hita, for an extensive session and a lesson on the new generation and the new techniques coming around. Of course, augmented reality has come into the question, and of course, BBRT, especially for the cases of triple PD, which have been coming into use. So, an excellent session. You have also covered the newer advances in vestibular rehabilitation. So, I request you to please step back for a few minutes, and
Yes, yes.
we'll take you back in the panel discussion. Over to you,
Sure.
Pitakin sir.
Thank you, sir. Thank you. Thank you, sir.
Yeah, thank you. So now we come to our next expert for the evening, Dr. Dinesh Singh. Dr. Dinesh Singh serves as the director of New Winds Hospital and Neurocare Center, Borivali. He also practices at Neuron Clinic while also working as a consultant neurologist at Bhaktivedanta Hospital. A gold medalist in MD General Medicine and university topper in DM Neurology, he has been honored with the Inspiring Neurologist Award by the Economic Times in 2019, along with recognitions from the Golden Aim Award in 2021 and Asian Healthcare Summit Awards in 2021 again. His key areas of expertise include stroke medicine and rehabilitation, headache disorders, and movement disorders, with a strong commitment to delivering advanced patient-focused neurological care. I now invite Dr. Dinesh Singh to deliver his presentation.
Yeah, am I visible? Am I audible?
Yes, doctor.
Yeah, I wanted to load my presentation. Presentation PPT. Yeah. Yeah, so are my slides visible?
Yes, doctor.
Okay. So shall we start?
Sure.
Right. So good evening, everyone. Thank you, AIB, for giving me this opportunity to uh, talk in today's forum. I thought I'd discuss a very practical topic, that is dangerous dizziness, what not to miss in your OPD practice in a dizzy patient. Now, I'll start off with the take home message. I have a lot of cases, everything I'll keep it as case based, not much of theory. So I'll start off with the take home message. All dizziness is not vertigo. Dizziness can be vertigo, can be stroke, can be of cardiac origin, can be hemodynamic, can be metabolic, can be extrapyramidal, can be psychogenic. So vertigo can be fun, but vertigo can be dangerous, particularly if you miss central vertigos. In my talk, if we are able to, understand how not to miss a posterior circulation stroke or a TI, I'll be very happy if we understand that much. Never miss an arrhythmogenic syncope. Identify atypical or different nystagmus. Atypical nystagmus is basically central nystagmus. And I'm sure because we are talking on the AIB forum, I think everybody must be knowing the HINTS protocol. So I'll not get too much into the HINTS protocol. So I'll start off with the first case. If I'm not audible or visible, please let me know. So this is the case of a 22-year-old female. This was a young girl whose picnic was cut short. So this was a 22-year-old female. She presented with headache and chakkar since the last 3 days. So she went to her local family physician. She went to her local family physician and she was put on naproxen and anti-vertigo drug combination. So she went for a picnic, but her picnic was cut short because she developed difficulty in walking on day 4 and she also developed left upper limb numbness on the 4th day. So again, she went to her family doctor and she was given injection B12 and clonazepam, but there was an MRI which was done. The MRI was normal. Nothing was there in the MRI. You can see the film. The MRI was absolutely normal. Now, this is her video. So, what is the finding? What would you like to do next? What is the possible diagnosis and how would you treat her?
देखो इधर जितना जा सकता है उतना इस तरफ देखो वापस से इधर देखो ऊपर देखो नीचे देखो नीचे देखो बस
Correct. So, what is the, you can unmute yourself and tell me what was the finding that you saw in this girl? Anybody can answer? Or you want me to, I'll tell you and then we discuss it later on maybe. So what you see in this girl is you have a vertical nystagmus, probably an upbeat nystagmus, as well as a gaze evoked nystagmus. So what test would you like to do next in her, and what is the possible diagnosis? The first thing is whether it is a central nystagmus or a peripheral nystagmus. So the point that I wanted to show here was whenever you have a vertical nystagmus, it is always central. It cannot be peripheral. So what would you like to do next? Her first MRI was normal. So we repeated our MRI on a 3 Tesla machine. And if you can see just around the fourth ventricle in the periaqueductal region, there is a hyperintensity that she has. Somewhere in the midbrain, in the lower midbrain and in the upper pons, she has a hyperintensity around the fourth ventricle. So this was, and if you see here in this image, you can see some T2 white matter hyperintensities even in the right parietal lobe. So that was probably the explanation for her left hand numbness. So whenever you have a vertical nystagmus, you re-image the patient. You might have missed the first MRI that was done for her was probably on a 1.5 Tesla machine. We repeated a 3 Tesla MRI and it showed a brainstem lesion as well as a cortical lesion. So this was possibly a case of demyelination. When we investigated her further, the workup showed that she was SLE positive. She turned out to be SLE and we put her on steroids and now currently she's on steroid with rituximab and she's doing very well. So it was an acute vestibular syndrome. It was central because she had a vertical nystagmus with hemibody symptoms. So whenever you have a vertical nystagmus and any patient of Chakkar tells you that I have anything on one side of the body, you should always look for a central cause, right? So now this is the story of a middle-aged male. He presented with dizziness and vomiting. So this was a 55-year-old male. He was brought by 5 relatives, hypertensive, diabetic, and dizziness and vomiting since the last 3 days. The dizziness was basically true spins. It was lasting for minutes to hours, non-positional, with severe nausea, vomiting, and sweating. There was no diplopia, no dysarthria, no heavy body symptoms, and he was on multiple anti-vertigo drugs, no relief. On examination, vitals were normal, there were no cerebellar signs, and no focal deficits. Now, what would you want to check in him? Now, see his video. So you can see he's got a left beating nystagmus. And when he's looking to the right, there is no nystagmus on looking to the right. The video is not very clear, but it's basically a left beating nystagmus. So this was basically just a left beating nystagmus on examination. So we went ahead and I did his head impulse test. So when I'm turning his head to the left, he's able to focus on my nose. Yeah, but when I turn his head to the right, the eye deviates and then comes back onto my nose. So this was a left beating nystagmus with a right head impulse test positive. So what was the diagnosis? It was an acute vestibular syndrome, peripheral or central. It was a peripheral vertigo because he had a unilateral nystagmus with a positive head impulse test. So diagnosis was right vestibular neuritis. Why he did not improve on these vertigo drug combinations? Because he was not given steroids. We put him on steroids, reassured him, and he improved in about 15 to 20 days time. So how do you differentiate central from peripheral vertigo? All of us know that this is possible. The main test that you need to do is the head impulse test to differentiate central from peripheral vertigo. This is basically some videos which I have taken from YouTube.
Component towards the left, and it increases when he looks to the left.
Whenever you have
the torsional component,
nystagmus,
when he looks to the right, it lessens, but the fast component
is a
is
peripheral
still
vertigo
towards the left.
This guy has a left
So
beating
it's
nystagmus.
unidirectional nystagmus. It doesn't change
Unidirectional
direction.
nystagmus is usually
Tori-
peripheral, whereas this is an animated video. Which shows a bidirectional nystagmus. Primary position, there is no nystagmus. But when she looks to the left, there's a nystagmus to the left. So whenever you have a unilateral nystagmus, it is by and large a peripheral vertigo. Whenever you have a bidirectional nystagmus, always look for a central cause, irrespective of your first MRI. Even if the first MRI is normal, should repeat an MRI and look for a posterior circulation stroke. So that's how you differentiate a peripheral from a central vertigo. Central vertigos, usually vertigo is less, they are more ataxic, and usually they don't have any ear symptoms, whereas in peripheral vertigo, they look more sick, they have more of spinning, less of ataxia, and in central vertigo, you will have some hemibody symptoms like diplopia, dysarthria, dysphagia, and in central vertigo, you will have a bidirectional nystagmus, whereas in a peripheral vertigo, you'll have a unidirectional nystagmus. And I always say that always remember these deadly Ds, which suggest a central cause. Any one of these deadly Ds, you should look for a central cause. Diplopia, dysarthria, dysphagia, dysphonia, dysmetria, or drop attack. So any patient with vertigo who says that I fall down or I have fallen down because of this spinning spell, always image the patient to look for a vertebrobasilar TIA. So head impulse, I'm not getting into the head impulse test. Now, this is basically a lady, 54-year-old female. She was a diabetic. She had history of migraine with aura since 20 years. Now she presented to us with dizziness since 1 week. Her CT was done. CT was normal. So she went to the physician, then went to the ENT, and then nothing was found. So she was referred to a psychiatrist. Now she developed headache on day 8. So the psychiatrist referred her to me. And you listen to her history, what she says.
आंखों के सामने मुझे झिकझैक शेप आती थी और चलने में भी इम्बैलेंस होता था और कभी 15-20 मिनट तक आंखों के सामने झिकझैक शेप रहता था और मतलब देखने में भी मेरे को तकलीफ होती थी, ऐसा हो रहा था।
चक्कर भी आ रहा था,
चक्कर भी आ रहा था।
So what she says is that she had this chakkar was the word that she used, as a result of which she went to multiple people. But the main point that was missed here was that she said that I am seeing zigzag lines in front of my eyes since the last 8 days, and then she developed headache. Now you look at the finding that she
देखिए
has. So you look at her sclera for the nystagmus, look at the conjunctival vessels, and you can see that she's got a left beating nystagmus, and when she's looking to the right, she's got a very subtle right beating nystagmus as well. See, when she's asked to look on the right, she has a right beating nystagmus. Now when you look at her gait,
इधर देखिए
that's her gait. It's very difficult for her to walk unassisted. And she's trying to do tandem walking.
इसको पकड़ो मत
She has to hold on to do tandem walking. She's unable to do tandem walking.
को देखिए
And that's her head impulse test. So her head impulse is negative. So she has a bidirectional
नाक
nystagmus
पे देखिए
with impaired tandem walking and some history suggestive of some visual phenomena in the form of zigzag lines with a normal CT. So what would you do next? So what we did for him is that this is basically a central vertigo, and it is most likely a posterior circulation stroke which was missed on a CT. So we did her MRI, and the MRI showed a small left occipital infarct here and a left cerebellar infarct. The cerebellar infarct was the reason for her chakkar. She had a bilateral cerebellar infarcts, right, which was small. The left one was a bigger one, and she had an occipital infarct. So the zigzag lines were basically visual phenomena coming from the occipital infarct, and the dizziness, the ataxia, the chakkar was possibly coming from the cerebellar infarcts. So her MRI angio showed a vertebrobasilar disease. She was put on antiplatelets, and now she's doing well. So very, very important that you do not miss stroke in your day-to-day practice. Whenever you have hemibody symptoms or any abnormal visual phenomena with the word chakkar, always image the patient. Now, this is an interesting case. So I'll not put his history on. I'll just tell you what the history was in brief. This elderly male, he was a case of IHD. He presented to us with history of chakkar and vomiting since 2 a.m. at night. He came to the casualty at about 5 a.m. in the morning, and he was unable to sit. He said, the moment I try to sit, I fall. That was his history. Now you look at the findings here.
इधर इधर
So you can see he's got a left beating nystagmus.
अभी इधर
And now when he's looking to the right, he's got a right beating nystagmus. So it's basically a gaze evoked nystagmus, right? Now look at his head impulse test.
नाक पे देखो अंकल नाक पे देखो नाक पे
So I
देखते
turn the
रहो
head to the left. He's able to
शाबाश
focus.
नाक पे देखते रहो नाक पे
And when I
देखो
turn the head to the right,
शाबाश नाक पे देखो
his eye goes away and comes back. So he basically has a gaze evoked nystagmus with a positive head impulse to the right. So whenever you have a positive head impulse, what we usually think is that it is possibly a peripheral vertigo. And this MRI was done because he came to the casualty, and the MRI was absolutely normal, nothing in the MRI. So was this central or was this peripheral? So whenever you encounter a patient who has gaze evoked nystagmus with a positive head impulse test, you should give more importance to the gaze evoked nystagmus rather than the positive head impulse test, because there is a condition where you have the infarct right at the root entry zone of the eighth nerve, and that was this case. He had an infarct right at the root entry zone of the eighth nerve, which when we repeated his MRI after 6 hours, and the MRI showed a tiny infarct at the root entry zone of the right eighth nerve. This is the image is opposite. It's on the right. The infarct is on the right, and he had a tight vertebrobasilar disease. So for this is basically a pseudo peripheral nystagmus. So you usually encounter this in medullary strokes where your eighth nerve just enters into the medulla and you have an infarct right at the root entry zone of the eighth nerve. You can also see this similar finding in a brainstem demyelination. So whenever you are encountered with a gaze evoked nystagmus and a positive head impulse test, you should give more importance to the gaze evoked nystagmus rather than the head impulse test. So acute unilateral cerebellar or brainstem strokes may look like vestibular neuritis, but the most important point is whenever you have a direction changing nystagmus, it has to be central, it cannot be peripheral, and you should always repeat an MRI again if your first MRI is negative. So these are the four common causes of acute vertigo. We all know this. Now, this is basically now we'll go away from vertigo and go to certain non CNS causes for
बोलिए
chakkar.
क्या तकलीफ हो रही थी अंकल?
मेरे को जब भी मैं उठता हूँ या वॉशरूम जाता हूँ या नहा के उठता हूँ या झुकता हूँ तो मेरा कान के ऊपर पूरा सर पूरा गर्म हो जाता है एकदम, और आंखों के सामने थोड़ा धुंधला हो जाता है। उसके बाद मेरा हार्ट बीट एकदम बहुत बढ़ जाता है, चक्कर जैसा आता है।
उठ के चल खड़े होने पे या
हाँ, खड़े होने पर या चल के जाने के टाइम पर,
हाँ,
या
और सोने पे ठीक हो जाता है?
सोने के टाइम पर ठीक हो,
बैठने पे
भी ठीक हो।
देखने में कुछ तकलीफ होती है?
देखने में तो
बोलिए।
Okay, so this was an elderly male, 65-year-old, recently underwent CABG. He had history of chakkar since 1 month. So all these people use the word chakkar. So he went to the cardiologist first because he had undergone a CABG. Then he went to a neurologist, ENT, and then to the psychiatrist. He had no relief in symptoms. His blood pressure was 120 by 80. Central nervous system examination was normal. His MRI was normal. His echo was done. His hemoglobin was checked. Everything was normal. Now the point here in history was what he said is कि I get चक्कर when I get up from sitting position and I feel कि सर के ऊपर सब गर्म हो गया. So whenever you have an orthostatic symptom, you should always first check for hemoglobin, next check for the blood pressure in standing position, both of which were normal. But fortunately, he had an event when I made him stand in my OPD, and I'm lucky enough to have a cardiologist just besides my OPD. I sent him for an ECG, and the ECG showed a supraventricular arrhythmia. So this was basically a case of arrhythmogenic syncope. So any elderly with a history of cardiac ailment who tells you that I have dizziness on getting up from sitting position and I get better when I lie down, always think of orthostatic hypotension, severe anemia, or an arrhythmogenic syncope. So this is a similar lady. I'll skip this. This is also arrhythmogenic syncope. So any elderly coming with dizziness, these are the three causes: orthostatic hypotension, arrhythmogenic syncope, and anemia of blood loss. What test you should do in these people? Standing blood pressure, CBC, hemoglobin, ECG, echo, and Holter if your MRI is normal. So now this is an elderly male. He presented with dizziness since 1 week. He was unable to walk without support. He was a known case of essential tremor. He was on medication for essential tremor, no hypertension, no diabetes, no IHD, no asthma. He was on multiple anti-vertigo drugs for the past 1 week, no relief. MRI normal, thyroid normal, B12 was normal. Now you look at his video, look at the nystagmus. Okay. So you can see he has a direction changing nystagmus. Ready? And when you look at his tandem walking, he's unable to do tandem walking. And when you ask him to do the finger nose test, he has severe incoordination. Bas, okay. And he was barely able to sit without support. He would have fallen down. MRI normal, everything was normal for him. One history that everybody forgot to ask was what medication he was on, and he was a case of essential tremor, as I said, and he was on tablet primidone. Now primidone belongs to the same group as phenytoin, and phenytoin is known to cause ataxia. So it was basically primidone induced ataxia. These are a few drugs which can cause ataxia. So whenever a patient of ataxia comes to you, always ask for these drugs: phenytoin, carbamazepine, oxcarbamazepine, lacosamide, lithium, metronidazole, aminoglycosides, and alcohol. So these are few toxic causes of ataxia. This I'll skip. The video is not very clear in this, so I'll skip this. This is easy. Okay, these are a few long cases. If we go with this, it will take a very long time for us to finish. Yeah. So this was a young male with paresthesias over the head and giddiness. So young male tingling over the head since 1 year, only on coughing, laughing, and sneezing. and dizziness since the last 6 months. Examination was absolutely normal because he had symptoms for the past 1 year. He was put on antidepressants. Now you see his video. His
طالع
MRI was
تحت
normal.
شوف يسار شوف يمين شوف فوق طالع تحت شوف تحت ايوه
So you see, he has a downbeat nystagmus. He's got a vertical nystagmus. His MRI was
You see
normal.
that?
So what would you like to do next? Whenever you have a vertical nystagmus and your brain is
طالع تحت
the second thing that you look at is the CV junction. So whenever you image the brain, you ask them for a CV junction as well whenever you are dealing with a vertical nystagmus. So he had a severe CV junction anomaly. He had an anal cavity malformation. You can see that the brainstem structures are sagging below the foramen of Monroe. So whenever you have a downbeat nystagmus, these are a few causes of downbeat nystagmus. So the important point is always look at the CV junction. That's very important. And I'll end with this case. So this is a young woman with ataxia since 1 year. You see her nystagmus. So she's got a fast beating nystagmus to the left and a slightly lesser frequency nystagmus when she looks to the right. With an additional finding, which is a left element facial nerve weakness. So she was being treated for Bell's palsy for the past 1 year. It's only when she developed ataxia that she came to us. And this is classically a Bruns nystagmus. So her MRI showed a large CP angle lesion. So you have an ipsilateral large amplitude, whereas large amplitude low frequency nystagmus, and a contralateral small amplitude high frequency nystagmus. That is classical of Bruns nystagmus. So these are classical of CP angle lesion. So central vertigo, always remember, it is more of ataxia, less of spinning. Do not forget the deadly D's. Direction changing nystagmus is the hallmark of a central vertigo. In central vertigo, the head impulse test is negative. Whenever you have hemibody symptoms, always think of central vertigo, and MRI can be initially negative. So I'll end with this slide, which I always put in any dizziness class that I take. That usually dizzy patients come to us, we make them more dizzy by taking them on a ride. We examine them, we say, go and do an X-ray cervical spine. X-ray cervical spine, most of us will have some element of spondylitis. So they come back to us, they show us the X-ray, we say, okay, look, you have spondylitis, and we make ourselves look so intelligent. Just in case by mistake, the X-ray is reported as normal. Then we check the BP. If it is a female, the blood pressure around 170, we say, okay, look, your blood pressure is low, uski वजह से चक्कर आ रहा है. Somehow the blood pressure is also normal. You look at the age of the patient, you say, अच्छा आपको brain में blood कम पहुंच रहा है अगर old patient है तो. And if it's a young patient, we say that there is a problem with your inner ear fluid. Finally, the patient asks us, अभी हमको क्या problem, what is our diagnosis, what is the problem we have. So we tell them that it is vertigo. And patients come to us, we ask them in our history as neurologists, आपको क्या problem है, they tell us it is vertigo. So the point to remember is vertigo is not a disease, vertigo is a symptom. These are a few dangerous and rare causes of vertigo, but you should not miss them. And the most important, again, thing that I always say, clinical examination still rules. Your MRI can be negative in central vertigos. It's clinical examination that tells you whether to repeat an MRI again. Right. Thank you very much.
Sir, thank you so much for incorporating time first and foremost and giving us a lecture again on AIB India. I know it is very difficult to get hold of you, but we are extremely thankful for having you in the program. And yet again, I know you're one of the best neurologists, no doubt, because we work in tandem and there is no doubt about it. And we continue to work together. And you continue to be on AIB's forum and keep us educating more on the neurological phenomena.
Pleasure.
So so just a 2-minute video, just a small break, and we come back to the panel discussion with the final 10 minutes. Some questionnaires are left which the audience want to know. So Pirakin sir, over to you for the small video, and then we come back for the panel discussion. Yeah.
Sure.
Okay, so I would like to ask my panels to join back for the final segment for the panel discussion. Yeah. Okay. So maybe some Dr. Suraj or Dr. Dinesh Singh may not be available. In case if they are, they can join in because they have they're still going the OPD as of now. So there are a few questions that I would like to take today. So, okay, now there is one, it's written from Telangana. Dr. Apeksha is writing that vertigo is a tough thing to diagnose with the cause of the session will have. Yes. So basically, vertigo is a tough situation to handle, but if you have a proper history taking and your skills are equally good for to have a good clinical examination skills, which includes ENT examination and a good neurotological examination along with the hence plus and the positional testing and gait examination, you're good to go because majority of the diagnosis is made on the history itself and the clinical examination. The rest of the test, as mentioned by Dr. Dinesh Singh also in his lecture, that is purely based on the confirmation of your diagnosis. But still, clinical examination rules over everything else. The next question that has been asked by Dr. Anju Mahesh is how to differentiate a posterior circulation stroke from labyrinthitis. Now, labyrinthitis means it is involving both your balance system and the hearing system. So basically, you would like to do an hints examination. In hints, your head impulse test will be positive. That means there will be a corrective saccade which will point out towards the peripheral vertigo. That is labyrinthitis. You'll have a unilateral or a horizontal nystagmus, and there will be no skew deviation. So these are the classical points which will point it towards the labyrinthitis. In posterior circulation stroke, you will have in case of hints again, you will have an hints. It will be negative. Head impulse will be negative. You will have a direction changing nystagmus or a gaze evoked nystagmus probably, or there can be a vertical nystagmus and there can be a skew deviation. So that will point towards the central part. Along with that, the dangerous Ds, the diplopia, dysarthria, dysphagia, and the other histories of the asymmetrical, the loss of sensation, that can be the other things that you can look into such cases. So this is how you differentiate the posterior circulation stroke from labyrinthitis. The next question that we have is the new trends in vestibular rehabilitation. Dr. Hitav is here. Dr. Hitav, if you can just highlight again on the new trends in vertigo rehabilitation.
Hi, ma'am. Yes. So, ma'am, the most important and the most advanced one is vestibular rehabilitation is the use of virtual reality and augmented reality. And there is a lot of robotics that is coming in, which is helping a lot of machine learning and lot of data-driven biofeedback mechanisms that are there. And along with that, tele-rehabilitation is the game changer right now, ma'am.
Okay. And of course, in cases of triple PD, as we were discussing, the virtual reality has also been playing a lot of role. But these things are only possible once the patient is clear of benign paroxysmal positional vertigo. So if you have not cleared the patient of BPPV, please don't start the vestibular rehab because you are then making the patient enter into something new normal. I hope, Dr. Hita, you will agree with me that if the positional vertigo is not
Yes.
clear, you cannot
No,
proceed with the rehab.
no, ma'am. The clearance has to come from the ENT surgeon or from the neurologist before we put a patient on the rehab protocol, ma'am.
Yes, because vestibular rehabilitation can only be started once the ears are clear. There may be residual giddiness. There may be the long-standing crystal itself can itself give a new compromisation or a destabilization or an uncompensated form of vertigo. But these all things require proper stepwise adaptation, habituation, substitution exercises along with development of the cognitive skills. So nowadays cognition is also given a lot of importance, especially in elderly populations too. Okay, now there is one question coming from Haryana, that is Dr. Sahib Singh Bhatti. So he is mentioning about, please discuss about Meniere disease in detail. So Meniere disease is a complex condition. Basically, it involves fluctuating hearing loss. There is vertigo and there is tinnitus. So the patient will have an aura of symptoms before it starts off. You know, they'll have some sound coming from the ear, huge rotatory spinning vertigo with an increased nausea, vomiting. They'll probably vomit also. and something which can also be like a medical emergency in such cases. So generally, Meniere's disease involves treatments with diuretics and beta histone, but with the advances in neurootology, there is something new which has come up, which is known as Meniere's migraine spectrum. So what you're missing basically maybe the history of migraine in such cases, like the history of headaches or the history of intolerance to light and sound. Baroness Society has recently removed the criteria of headaches also. So if the patient is presenting with photophobia, phonophobia, nausea, vomiting, or with heaviness in the head, you can always consider that patient in the Meniere's and migraine spectrum. Of course, you will require less of investigation because generally it presents with unilateral hearing loss. So MRI brain should be done. It's a good thing that you get rid of it. And along with that, you can do an audiogram. You can also perform an audiogram with glycerol test before starting a diuretic to see if there's an improvement with in the testing. So that helps you with the Meniere's disease treatment. Now, considering how to start, so first see the patient, see if it is it's a mild, moderate, severe. In acute cases, you tend to give vestibular suppressants. In prophylactic treatment, you tend to give beta histone at doses. So, and you can add a diuretic based on the treatment. And of course, the patient has to maintain a low salt diet also to improve and have a good lifestyle and dietary modifications to maintain in Meniere's disease. There is a question coming from Dr. Reshma. Is there any hands-on? Hands-on, we have a separate academy, so you can contact us for the same for that in the same. Unsuccessful vertigo due to Meniere's disease. So basically, it can be there's something known as unsuccessful treatment of vertigo in Meniere's. So these are the intractable cases, or maybe the migraine history has been missed by the patients. So in that case, you need to understand if there is a migraine criteria or there is underlying psychological factor that may be affecting the patient and presenting in such cases. Or in intractable cases, you can always ask the patient to go for surgery because that will be helpful to patients in such cases. So with this, I think since my guest speakers are already back to their OPD, I think I have taken a majority of the questions. If there are still some, we can wait for another 5-10 minutes, or again another 5 minutes before the closures. Vinayak, you can put the final slide. So if you have any questions, you can please put up in the chat box. I'm here to answer all your queries. Dr. Hitab is also there with me if you have something to be asked on rehab. So, as I go towards the closure, I would like to thank my team at AIB India. I would like to thank Pinakin Munshi sir for again being a great host for the day, the Saturday evening. I would like to thank my speakers, Dr. Hitav, Dr. Suraj, and Dr. Dinesh Singh, especially for joining in for our third series of VERTICON. And I would like to thank my team at DocMode, who have done a lot of work and in coordination with doctors and setting up the entire platform and the program. And we look forward to having you in more in the sessions this year, more both in online, offline, or maybe in the workshops that AIB India conducts in coming days. So thank you so much for joining in. Thanks to all the delegates who has joined from our own country and international also. Over to you, Pinakin sir.
Yeah. So we look forward to seeing you all again, our panelists as well as the participants for upcoming sessions, as Dr. Neha has already mentioned. And I think it's time to say goodbye. So until then, thank you once again. Have a wonderful evening and a relaxed weekend. Thank you very much.